Good morning, class. Welcome to our session on the disorders of the adrenal gland as well as endocrine hypertension. So this lecture series will be composed of 5 parts. So watch out for the next videos after this one. So for the first part of this session, we're going to talk about the adrenal gland anatomy and physiology and an overview of the disorders of the adrenal cortex. So before we start, I'd like to give you an overview of what you guys should be learning from this lecture series. At the end of the class, you guys should be able to, number one, recall the anatomy and physiology of the adrenal gland, understand steroidogenesis, metabolism, and action. I know that steroidogenesis has been discussing you in biochemistry, but it appears to be very abstract, but I'll try to give you an idea on how it can be applied in clinical practice. And then we're going to identify patients with signs and symptoms of hypercortisolism and mineralocorticoid excess, particularly your Cushing syndrome and your primary hyperaldosteronism. And also, we're going to discuss how to formulate an approach to the diagnosis of patients with adrenal incidentaloma. And then we're going to proceed to, you guys should be able to recognize patients with signs and symptoms of adrenal insufficiency and congenital adrenal hyperplasia. And then at the last session, the last part of the lecture, we are also going to try to distinguish patients suspected to have pheochromocytoma. And lastly, you guys should be able to apply the principles above in the approach to a patient suspected to have endocrine hypertension. So as a review, the adrenal gland is composed of 3 layers. No? So you have your zona reticularis. Let me just change my pointer. So our adrenal gland has two major layers. You have your cortex, your outer cortex, and your inner adrenal medulla. And of course, your adrenal cortex is composed of 3 layers: your outer glomerulosa, middle fasciculata, and your inner zona reticularis. And each layer has a predominant hormone that is being secreted in each layer. So for your inner zona reticularis, the class of hormones that are predominantly secreted there are your androgens, and the major androgenic hormones would be your DHEA or your dihydroepiandrosterone, and your most abundant androgen, which is your androstenedione. And this is specifically stimulated or controlled by your ACTH. Next is your middle fasciculata, and the major class of hormones that is secreted in this layer are your glucocorticoids, and the major hormone representing your class of glucocorticoids is your cortisol, and it is predominantly controlled by your ACTH. Then finally, you have your zona glomerulosa, the outermost layer of your adrenal cortex. And the predominant class of hormones secreted here are your mineralocorticoids. And the major mineralocorticoid hormone is your aldosterone. And this is unlike your androgens and your glucocorticoids, your mineralocorticoids are predominantly controlled or stimulated by your angiotensin 2. Sorry, that's a typographical error. Your angiotensin 2 and your potassium. So to help you remember, I don't have a fancy mnemonic for this, but this is usually the set of mnemonics that I've memorized since I was in first year med school, and even when I during my fellowship and my endocrine board exam, this is what the mnemonics that I still use up to now. So I just remember RAFGGM, reticularis, androgens, fasciculata, glomerulosa, glucocorticoids, glomerulosa, mineralocorticoids. So your adrenal medulla, on the other hand, are the layer the layer that is responsible for secreting your catecholamines. So your cortisol, the major glucocorticoid secreted by adrenal glands are, remember that your adrenocortical hormones are, your steroid hormones are lipid soluble hormones. So therefore, when they freely diffuse into the lipid biomembrane. However, they need to bind to plasma proteins in the bloodstream uh, in order to reach its target receptor and prevent itself from being prematurely metabolized. So your cortisol is predominantly bound to plasma protein. So the specific plasma protein is your cortisol binding globulin or your transcortin, and to a lesser extent your albumin. And this plasma protein binding slows the elimination of your cortisol, now making its half-life between 60 to 90 minutes. Next is your aldosterone. Your aldosterone is your major mineralocorticoid hormone. This is less bound to your plasma protein, so only 60%. So therefore, the half-life is a bit shorter, compared to your cortisol. So how do we control um, the secretion of the synthesis and secretion of your steroid hormone? So I'd just like to review the hypothalamic pituitary adrenal axis, and how this axis is regulated. So the hormone coming from your hypothalamus, the releasing hormone is your CRH or your corticotropin releasing hormone. And remember that the it it acts on the DNA that encodes your pro-opiomelanocortin and stimulates its protein synthesis and eventual cleavage of your pro-opiomelanocortin. And remember that your pro-opiomelanocortin has several cleavage products, and one of those is ACTH. So your ACTH is the main pivotal regulator of your adrenal cortisol synthesis. It has it has some short-term effects on mineralocorticoid and adrenal androgen synthesis. But remember, the predominant control of your mineralocorticoid secretion and synthesis is your angiotensin 2 and your potassium. So just like your cortisol, your ACTH, as we discussed in the previous sessions, has a pulsatile secretion and follows a circadian rhythm that mirrors the circadian rhythm of your cortisol. So the axis is affected by your circadian rhythm as well as physical and physiologic stressors. So any stress from the environment and any stress within the body, such as fever, hypoglycemia, hypertension, can activate or put your hypothalamic pituitary axis into activation. No? And all these are negated in your hypothalamus, and then your hypothalamus now will secrete your CRH, and your CRH now will stimulate your anterior pituitary to secrete your ACTH, and your ACTH now will act on your adrenal cortex, specifically which layer. You remember the layer where cortisol is. So cortisol is glucocorticoid, RAFG, so it's zona fasciculata. Okay, that secretes your circulating cortisol. And the circulating cortisol will now send a negative feedback to your anterior pituitary and your hypothalamus in order to avoid overactivity of the hypothalamic pituitary adrenal axis. So remember I told you about the circadian rhythm of your cortisol. So this graph shows the physiologic cortisol circadian rhythm. So I put here that remember this because this is crucial when interpreting hormonal testing related to your hypothalamic pituitary axis. So remember from our previous session that the peak of your cortisol secretion usually starts between 8 to 9 8. 8 to 10 a.m., no, that's the peak, and then it gradually goes down and reaches its nadir or lowest point at around 12 midnight. No? So if there are any disruptions in your circadian rhythm, it can also disrupt the cortisol circadian rhythm as well. So remember, the peak is between 8 to 10 a.m. and the nadir or the lowest levels happens at around 12 midnight. Okay? How about the mineralocorticoid axis? This is regulated under your renin-angiotensin aldosterone system or your RAAS. No? So remember that your mineralocorticoid axis is mainly controlled by this system and only to a lesser extent by a very minimal extent by your ACTH. No, so first, no, this axis and this system is uh, triggered by, affected by the circulating blood volume. If there is any reduction in the circulating blood volume, for example, there's massive blood loss or sudden hypotension, it will result in a reduction in renal perfusion pressure. And this will be sensed by our kidneys, specifically your juxtaglomerular cells. And then your juxtaglomerular cells will now release its renin. And the renin now will activate the conversion of your angiotensinogen to your angiotensin 1. And your angiotensin 1 will be converted into your more potent active angiotensin 2. And this is facilitated by your angiotensin converting enzyme located in your lungs. And your angiotensin 2 is a very powerful vasoconstrictor in the body and results in vasoconstriction, therefore reducing the vasoconstrictor will increase your renal perfusion pressure. No? It's like a negative feedback mechanism. It's a feedback mechanism as well. And aside from stimulating vasoconstriction, your angiotensin 2 also activates your angiotensin 2 receptor, type 1 or your AT1 receptor, and this causes the release of your aldosterone from your adrenal cortex. Remember what layer is your aldosterone secreted or synthesized? So remember R, A, F, G, G, N. So GN, it's in your zona glomerulosa. So your aldosterone, now the effect will be renal sodium retention and potassium excretion. And when you retain sodium, remember your sodium will help maintain intravascular volume. So in order to maintain renal perfusion pressure. Okay, very simple. I hope it's clear.